Hello and welcome. Thanks to everyone who is joining us today. We are going to give it a couple of minutes so that folks can join us from the waiting room. Okay, we'll go ahead and get started. Thanks again, everyone, for joining us for today's webinar, Enhancing and Strengthening the Behavioral Health Workforce, How to Meet the Needs of Rural and Frontier Communities. My name is Monica Porter Gilbert. I use she, her pronouns, and I work at the Bazelon Center for Mental Health Law. I'm a white 30-something woman with brown hair pulled back and black-rimmed glasses. I will be facilitating today's webinar, and we are very glad to have you with us. Before we get started, some notes on access and logistics. American Sign Language interpretation is available. We also have captioning available. If you are not seeing captions, please click on the CC icon at the bottom of your screen. Slides and a recording of today's webinar will be available on the Bazelon Center's website, and we will be emailing it out to all registrants. If you need any technical assistance today, please send a message to Kathy Chamberlain. And we would love to know where everyone is joining us from today. So I'll take a moment to pause. Please let us know in chat where you are joining us from. This is awesome. I see we've got folks joining us from all over the country. I am seeing New York, DC, Texas, Philly, Indiana, California, and Barbados. Welcome, everyone. We're very grateful to be joined by a panel of experts from across the country, from Alaska to New York, to share their experience and lessons learned. For the sake of time, I will let them introduce themselves as we go through our presentation today. We have a lot to cover. Our goal is that by the end of today's webinar, you will be able to understand the unique mental health needs of people in rural and frontier communities, to hear from multiple real-world successful examples of programs providing mental health services in rural and frontier communities, to learn how to leverage various funding sources to pay for mental health services, because we know budgets are always a consideration and a concern, and to actively engage with presenters and each other to address any questions you might have about bringing these programs to your community. We invite you to engage in chat, to check in with others who are joining us. And as you have questions that come up, please use the Q&A function so that we can keep track of your questions and make sure we are able to answer them. After a brief introduction, I will turn it over to our esteemed panelists from Technical Assistance Collaborative, from Alaska Behavioral Health Aid Program, and from New York PharmNet and we will be sure to save time for questions at the end. So please do, as I said, use that Q&A function. So to officially kick us off, I am joining you today from the DMV area. I work for the Bazelon Center for Mental Health Law. We are a national nonprofit organization, and our mission is to protect and advance the civil rights of adults and children with mental health and developmental disabilities. We do this through research, policy advocacy, community engagement, and litigation. And central to our first 50 years as an organization has been working to increase access to home and community-based mental health supportive services. A critical starting point for our conversation today is recognizing that a call for help involving mental health needs must receive a healthcare response, the same way that calls for help involving physical health needs do. Generally, if someone is experiencing a physical health crisis, such as a heart attack or a stroke, they receive emergency medical care from health professionals like paramedics or EMTs. A person who is experiencing a mental health crisis should similarly receive a healthcare response from a system that is designed to serve them. In communities around the country, we see the benefits of sending mental health responses to mental health calls. In the short and medium term, mental health responders are able to de-escalate mental health crises, to provide immediate emergency counseling, to help people remain in their housing and receive any needed care, and to successfully link people to community services. Over time, providing mental health responses to mental health calls leads to system-wide benefits, including reduced hospitalization rates and lengths of stay, reduced frequency and intensity of future crises, reduced criminal legal system involvement, and increased participation in community services. By providing appropriate and effective responses, communities across the board see significant cost savings due to decreased cycling through more costly and less effective resources. And of course, better outcomes for members of the community. There are many considerations for providing an effective crisis response system. While no two communities are alike, some general goals are to provide timely responses, as timely if possible as other first response programs. Responses that are available 24/7, that are voluntary, that are accessible to people with disabilities and people with different language needs, that are led by people with lived experience of mental health, substance use, homelessness, and criminal legal systems, that are trauma-informed and culturally responsive, and that provide effective linkages to community services and effective planning to promote long-term stability and reduce the likelihood of a future crisis. The proof is in the pudding. The best way to know if your system is working is to look at the outcomes. And when we have positive outcomes, we can move forward to scale up those pilot programs. In addition to the programs that we are featuring today, we'd like to take the opportunity to lift up some additional examples of mental health services that are responding to communities' tailored needs around the country. In Houston, Texas, the Crisis Call Diversion Program places mental health counselors within 911 dispatch to provide a 24/7, 365 mental health response to mental health crisis calls. In 2024, last year, the Crisis Call Diversion Program processed over 7,500 calls for service to 911, including over 3,200 calls that otherwise would have gone to the police. With a team of just 8 crisis phone counselors, 2 supervisors, and an annual budget of less than $500,000, the Crisis Call Diversion Program resulted in $2.7 million in cost savings for the City of Houston in just one fiscal year. When call centers like these are staffed by people with behavioral health expertise, many calls and texts can be resolved over the phone and don't even need an in-person response. In the event that an in-person response is needed, that response should also be mental health led. In Denver, Colorado, the Support Team Assisted Response, or STAR program, uses mental health crisis teams to respond to a wide variety of calls. Their 3 most common call types are requests for welfare checks, trespassing, and resolving mental health or substance use emergencies. From June 2020 to February of 2024, Denver STAR teams responded to over 8,000 calls that would have otherwise gone to the police. In 2022, a Stanford University study found robust evidence of the STAR program's success. This included a 34% drop in low-level crime and found that the cost of dispatching STAR teams was 1/4 the cost of dispatching the police. When people with specialized training, including peers, serve on mobile response teams, upwards of 70% of responses can be resolved in the field. In only a small number of cases, does an individual need to be transported somewhere for stabilization, and in most cases, returned to the community. In terms of an example of a place that people can go if necessary, in Pennington County, South Dakota, the Pivot Point opened in 2023 to provide both 23-hour mental health crisis assessment services and, as needed, up to 5 days of crisis stabilization, during which individuals may be linked to community-based services. Recognizing that an overwhelming number of the individuals who had been cycling through the jail and 85% of individuals receiving services at their care campus identify as Native American, Pennington County is working with organizations and experts that focus on providing culturally responsive supports, such as through the Indigenous model of restorative practices. Zooming out, last year, more than half of the United States population was identified as living in a mental health professional shortage area. We know that this can particularly be an issue in rural and frontier communities. The USDA has a number of programs and resources to support rural communities' health and quality of life. Because many of these programs don't have the word health in their title or in their description, and they can sometimes be hard to find, the USDA has created a rural health inventory tool and resource guides. All of the links in our slides will be sent to everyone who's joining today as well. So again, to tee us up for today's conversation, no 2 communities are exactly alike, but we know that there are some key considerations for providing community-based mental health services in rural and frontier communities. This includes reaching people across wide geographic areas, developing trust, and being responsive to unique mental health needs and stressors. I'll welcome anyone to share any questions in chat or through Q&A. And for now, without further ado, I'm very pleased to pass the mic to Rebecca Boss from the Technical Assistance Collaborative.
Thank you so much, Monica. My name is Rebecca Boss. I go by Becky and I use she, her pronouns. I'm a white woman with red hair. I'd prefer not to disclose the decade of my age. And I am very pleased to be with you here today. I'm a consultant with the Technical Assistance Collaborative in Boston. And while you have heard about some and will hear about some wonderful programs specific to serving rural communities, I'm hoping that we can have a conversation around some of the larger framework development for enhancing and strengthening behavioral health services in rural and remote communities. Next slide. In thinking about behavioral health disparities specific to rural and remote areas, I want to start with a definition of what health disparities are. They're preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. And so, what are some of those factors that we consider in creating health disparities? Factors such as poverty, environmental threats, inadequate access to health care, individual and behavioral health factors, and educational inequalities. And what I'd really like to emphasize here is the word preventable. And the question that we need to think about is how can policies, how can programs act to prevent disparities in each of these areas? Next slide. In considering rural behavioral health, you think about the 4 A's. The first one, accessibility. So, how long do you have to travel to be able to receive services? Are you less likely to be insured for behavioral health? Are providers where you are more likely to overlook and not diagnose and recognize a mental illness? Availability, looking at things like workforce. So, chronic shortages in behavioral health professionals exist, and behavioral health providers are more likely to be located in urban centers. Affordability, do you have the access to pay for the health services that you need? Do you have to cover out of pocket expenses? Is this a barrier to receiving the care that you need? And finally, acceptability. When you think about rural residents may be more susceptible to the stigma that exists really throughout our communities, but in rural areas, needing or receiving behavioral health care in small communities where everyone knows each other and fewer choices of trained professionals are available, you might lack faith in whether or not your information will be maintained as confidential, as well as, reliance on the informal care of family, friends, religious leaders. Next slide. If you think about intersectionality, so we look at these 3 circles, each one presents unique circumstances and challenges, and the intersectionality of these identities, these specific populations in rural areas, presents enhanced challenges that need to be considered. In terms of demographics, is it an aging population? Is it a population of historically marginalized peoples? Behavioral health and other disabilities, are there, to the slide earlier, is there acceptance of behavioral health in certain communities? And all of the issues related to the rural accessibility that we just talked about a moment ago. Next slide. So then the emphasis is on creating intentional health equity policies in each of these areas. In thinking about place intentional policies, rural, remote, are your policies, regulations, funding addressing the 4 A's, things like expecting network adequacy with your managed care organizations, and looking at things that promote the workforce availability in rural areas? For behavioral health and other disability intentional policies, are policies designed to promote inclusion of the disabled, including individuals with mental illness? And finally, are policies intentional in impacting the lives of historically marginalized folks? Are you looking at the inclusion of cultural sensitivity in contracts, the MCO service contracts addressing the needs of each specific population within a certain area? Next slide. CMS provided a framework for rural health policies that I'd like to present to you here today in order to advance healthcare in rural, tribal, and geographically isolated communities. The first priority in this framework is to look at community. Community is key. What information is available at the community level? What data services exist? Community informed can be data, but it can be more. It can be engaging with the community to find out what's needed, really going on, what's really going on, and what is the need, what is the gap, what are the barriers. In the second priority area, looking at improving the data. Where are the gaps? Who are the people that are missing? Who do we know about and who don't we know about in the data that's available? And how can we improve amongst the rural communities the collection of that data in a way that will support strategy? Workforce, we know, is a primary concern. And so are there opportunities to strengthen and support and expand workforce, to look at regulatory barriers, to look at professional credential barriers, certification barriers, to look at opportunities to incentivize professionals to work in rural communities? Can you use things like stipends, housing support, look at the wages available for individuals? Priority 4 is really looking at the use of technology. We know that when you have to travel 5 hours to get to an appointment, you're going to lose people who aren't able to get there. And can we use telehealth more effectively in rural communities and other technology supports to enhance our ability to engage with people in meaningful ways? Priority 5 is looking at the barrier to healthcare through health coverage and thinking about specifically rural populations in terms of maintaining adequate health coverage. And then finally, thinking outside the box, really driving innovation, looking at value-based care, thinking outside the box, engaging people outside of the usual suspects to determine how we can come at creative solutions to meet the needs of individuals who are representative of these populations in rural areas that are so challenged. Next slide, please. And I believe that is the end of my presentation. And thank you all for being part of this, and please keep in touch with Jack. Do I turn it back to Monica?
Thanks, Becky. This is Monica. We will now turn it over to our friends at the Alaska Behavioral Health Aid Program.
Excellent. Hi, good morning. My name is Xiomara Owens. I usually go by Zio, and I work at the Alaska Native Tribal Health Consortium in Anchorage, Alaska. I am a early 40s Black Puerto Rican Cuban woman with, let's say, a caramely chocolate skin tone and a high bun with my locks this morning. And I am joined by one of our long-term behavioral health aides, Josie Garney, who I will turn it over to her to give a brief introduction before we get started.
Okay, I'm Josie Boyana Garney. I'm Inupiaq female in my 50s. I work as a behavioral health aide in Teller, Alaska for the Norton Sound Health Corporation. Teller is a Inupiaq village with about less than 300 people northwest of Nome.
Perfect. This is Zio again, and we can move to the next slide. As we get started, it's helpful to have some context for the development of our health aid programs in Alaska. Alaska does have a history of colonialism that left a lasting impact on the health of our state, in particular, Alaska Native people. In the early 60s, colonialism ended up bringing epidemics such as the flu and TB to our state, and it really impacted our most rural and remote communities, and a lot of people and family members died as a result of that. Because of the location of these communities, access to regular health care and higher levels of care was pretty difficult. And so a natural response to that, what became a grassroots approach to caring for community members, where community members were taught and given skills, taught how to take care of their community members and given skills to be able to take care of their community members in absence of higher level providers in those communities. In the early 60s, this started with the medical arm of the community health aid program. And it really grew and it became very successful. So like I said, the community health aid program, it started with the medical arm, and these individuals, as this workforce has grown, have really become the front line of healthcare services in our villages throughout the state. For community health aid, the medical arm, their scope of work ranges to include everything from well child visits and preventative care to everyday medical needs to emergent care. If there's ever some kind of emergency in a community, they are the first ones to respond to it. The model became formalized over the years, and its success was the foundation for expanding to include dental health aides starting in the 90s. And then the third arm of the health aid program is the behavioral health aid program. And we were formalized in the late 90s, early 2000s. And so behavioral health aides, they really, this program has been designed and developed to address the behavioral health concerns that had shown up in our Alaskan communities, including suicide, substance use, substance-related mortality, domestic violence, and other effects of historical trauma. Next slide, please. And if you can click one more, looks like my animations are not coming through. Perfect, thank you. So this slide really just shows you how big Alaska is and how complex our system is. So we are the largest state in the United States. We are nearly two times the size of Texas. We have 11 distinct geographic and cultural communities. We have less than 1 million people, not even 750,000 just yet, which really equates to 1.3 persons per square mile. And that goes to tell you how we are defining rural and remote in Alaska. Nearly 2/3 of these communities have less than 500 residents. As Josie just mentioned, her community has 300. And 31% have less than 100 residents. 25% of communities are on the road system. What that means is, as you're seeing some of these dots on the map here, people are not able to just hop in their car and drive from one community to another. They are using mostly off-road vehicles such as ATVs, snow machines, boats, and small planes as a primary means of travel. And that is only if the weather allows you to. 10% of Alaskan residents live in remote communities, and of those residents, 80% identify as Alaska Native or American Indian. And so as you look at this map, you can see where oftentimes people are first receiving their care in a rural community, in a village, in a community health clinic, and those clinics are run by health aides. If they need a higher level of care from that, they might then take a boat or a plane to a sub-regional clinic where there's a higher level of care. And if they need an even higher level of care than that, they can go to their regional hospital, and even higher than that, if they need tertiary or more critical care, they would be flown to Anchorage to the Alaska Native Medical Center. So this is a very complex yet established system in Alaska that helps give people better access to care. But again, in our rural communities, it is primarily behavioral health aides, community health aides, and dental health aides that are providing that care. Next slide, please. So this slide just puts a face to the name. We have a conference every year where our behavioral health aides come in. and attend training and also just connect with people, because oftentimes BHAs are the only behavioral health provider in their community. And it's nice to be a part of and see the rest of the system that you are a part of. The BHA program, it is a workforce and it's also a certification program. So the workforce, they use a combination of Western and traditional based practices to provide behavioral health prevention, treatment, and recovery services. And for certification, this is the part where they are getting the training and developing the competencies that allow them to be able to provide these services. There is a certification board that is in place that oversees and makes sure that people complete their requirements for certification. And there's also a system in place where they have regular access to clinical supervision. They have an established scope of practice, and they have continuing education that helps maintain their knowledge, skills, and abilities. I thought it would be helpful. In my role, I talk a lot about the nuts and bolts of the health aid program, but I think it's really important to hear from the people who are actually providing the services. And so this is where I would like to turn it over to Josie to talk a little bit about your experience as someone who was born and raised in rural Alaska. What does it mean to you to have your communities have access to behavioral health services? And what does it mean to you to be a behavioral health aide?
Yeah, I've been working as a behavioral health aide since February 2nd, 1997. And to me, it means a lot. When I was growing up here in Teller, we didn't have behavioral health services that was available. And so like when my family went through some traumatic events, there wasn't anyone here to help out. And like now my children and my grandchildren will have an opportunity to get more services and culturally relevant services. So like I mentioned, I've been here since 1997, and in that amount of time, I've probably worked with a dozen or more behavioral health clinicians, master's level, that travel out to provide services. And so I'm able to act as a liaison for that person, for the provider that comes here. I can make sure that the services that they're providing are culturally relevant, that they're understanding our clients, that our clients are understanding them, and I can be the one that connects them to those services. We do have a lot, like she mentioned, we have a lot of suicide rates. Up until the 1960s, it was unheard of for there to be Alaska Native youth suicide, and since the 1960s, every 5 years, that rate has been doubling. And so this is my family. These are the people I care about, and I want them to get those services and to have help and to reduce those rates, and just to have happier, healthier people. And so that I can be here providing like a safe space for people to come in and helping connect them to services that they need. Just, it really means a lot. It's more than just a job. It's something that I really care about because it's my family. And for me, being a behavioral health aide, it helps, and to be a certified behavioral health aide, it gives me a scope of practice. And so it helps my clinical supervisors understand what I can do. Like I can say, I can do that. I can do the intake and screening. I can do the substance use assessment. I can provide the substance use treatment. I can do presentations at the school. It tells me what I can do. And at the same time, it also protects me from doing things that I should not be doing. It gives me, and it gives like a standard. Like I mentioned, I went through lots of clinicians. I also have worked with a lot of clinical supervisors, and it just helps there to be more of a standard care. Did you want to add anything to that, Zio?
No, that is perfect. Thank you. This Zio again. We can move to the next slide, and I'll have more questions for you, Josie, in just a moment. So this slide here really, from a certification board standpoint, it summarizes the scope of practice of behavioral health aides. As you can see here, there are 4 levels of behavioral health aide. So BHA 1, 2, 3, and the highest level is a behavioral health practitioner. Their scope of work, it builds on itself. So everything you see in BHA 1, as you advance to BHA 2, it includes that earlier level scope of practice as well. The scope moves along a continuum of care. So BHAs are providing prevention services, initial early intervention, and post-vention services. as Josie mentioned, doing a lot of screening, community advocacy, wellness, case management, but they are also, as you move into BHA2, learning a lot about how to help people who experience substance use and substance misuse disorders. And so they are learning how to do the assessments and treatment. And then as they advance, they learn about how to work with people who have co-occurring disorders as well. Josie, I wonder if you can take a moment to describe what a typical work day or week looks like for a BHA, and or identify some of the most common behavioral health topics or concerns that you work with as a BHA.
Yeah, one of the first things I learned was that there's not always a typical day or typical week. It really, the work that we do goes by the season, so like how much sunlight and daylight there is. We get really busy with crisis stabilizations in the springtime. Like when it starts to get lighter and brighter out, we do get a lot more crisis calls. And so like behavioral health aid ones, we're the ones, or all the behavioral health aides, we're usually the first point of contact in the villages. And so we're the ones who do the screening and intake and make referrals if they need them. We do have a behavioral health aid one on right now, Audrey Kalawi from Savunga. So I just want to recognize her. And she's been working really hard. She does a lot of the screening and intakes. For our region, we do try to have the trainees do more of the screening and intakes so they can get the practice. They start off by shadowing the behavioral health aid 3s or practitioners and helping them with the screenings intake. And then eventually we turn them over to them. And we're able to do that through video, like we are right now on Zoom, or through the telephone if someone doesn't have access to video. Because we are from our villages and live in our villages, we are also really closely related to everyone. So there are times when it would not be appropriate for me to work with somebody here in Teller, but like Audrey and Savunga may be the person who can do their screening, and I can help arrange that. But typically we do a lot of prevention and outreach, trying to let people know and teach people about behavioral health and letting them know it's available, getting people more comfortable with what it is. Because the help system can be kind of tough to navigate, and we're the ones who can learn what all the resources are, like how to navigate the system, and we can walk alongside our community members so they can get the most out of it. And so after the intake and screening, we give people a choice. Most people would probably want do integrated services for both substance use and mental health. And there are some who only want to do the substance use services. So we give people a choice. We do motivational interviewing to like maybe help move them through, like if eventually they might want to work on something else, like once they complete the substance use, there are other issues that come up that they might want to work on. We can refer them to the clinician that travels here. I do have a clinician that just flew in this morning on the plane. We tease him that he's a bad luck traveler every time he's going to come here to tell her the weather's bad. So he's here for the first time in 3 months. He just landed this morning, so he'll be busy meeting with clients today, doing the integrated and mental health assessments for us. And we also connect people to other resources. I think the average income for Alaska per capita is about 70,000, but here in our region, the villages, it's 10 to 20,000. And so we see people that come in that are hungry, that just don't have enough food. And so we can connect them to resources. And we also do teaching. Like one of the outreach activities that I'm doing right now is we have a sewing machine and material here. So we make bags for going out and picking greens. We do foraging. And so we teach people how to go out and do fishing, find nets that are available for community use. So there's not really a typical day. We do anything and everything. We're the first person that people come in. So even if it's something that we can't do, we can connect them to somebody else who can help. We try to turn anyone away for anything, even if it's something that we don't do. We want to help them because when they are in a crisis, and if we've turned them away for something little before that wasn't really our job, they remember that. And so I think we try to go out and do outreach and help people. So like when they are having a hard time, that they think of us and come to us.
Perfect. Thank you, Josie. If we can move to our next slide. I think as Josie, this is Zio again. As you heard from Josie, a perfect example, the clinician hadn't been out there for 3 months. And a part of it was bad weather that can prevent them from being out there. So this is another example as to why it's really important that we have health aides in our communities throughout Alaska. And this slide is really just showing that, just as Josie said, anyone that comes in the door, they are often the first people that greet them, and they are the ones who are helping them. So it doesn't matter your age, or if it's for individuals or a group, BHAs are providing services for everyone and anyone who needs them in the community. And the last thing that I will do is just really highlight that this program does a beautiful job of integrating traditional knowledge with clinical best practices. So when we talk about the interventions that BHAs are using, as Josie was mentioning, we're getting people out berry picking, we're teaching them how to fish. Those are mindful activities that make the most sense and are most effective for people that we are serving. So I will pause there. Josie, if there's anything else that you want to say, I think this is where we're going to close up, highlighting the BHA program. Do you have anything else you want to say about being a BHA, Josie?
No, I just really appreciate all the help that we get. We have like remote clinicians, we have clinicians that travel here, we have clinical supervisors that move here, and they're all really great people who want to help. But I'm really glad that we have behavioral health aides that are here to help them help better, so that they're following our community norms and our practices. And I think we help them do a better job.
Great. So Monica, I think this was our last slide. We'll turn it back over to you.
This is Monica. Thank you both very much. Oh, and I will now, did you want to say anything about that one?
No, I forgot that was on there. It's just a number of resources. Sorry, this is Zio. Resources related to the history of the health aid program. I guess this is also highlighting the fact that because this program has been so successful in Alaska in bringing care closer to home for our rural and remote communities, it's now being expanded into the lower 48. There are many communities in the lower 48 who have similar limited access to care and would like to use this model to help bring care closer to home.
Thank you both so much. We'll now transition over to our final presenter, Greg from New York FarmNet. And as we switch over to Spotlight Greg, thanks to those who are already putting questions in the Q&A and the chat. Please continue to do so, and we will look forward to opening it up for Q&A at the end of our presentation. But now, very excited to turn it over to Greg.
Thank you, Monica. Welcome to everyone. Pleasure to be here and looking forward to talking to you about FarmNet and who we are. My name is Greg Merck. I am the executive director of New York FarmNet. I go by he and him, and I'm the older white gentleman in the crowd this afternoon. So next slide, please. New York FarmNet, what makes us different? We look at the family's needs from a very holistic perspective. Each case that we work on is initially assigned a team, a social worker, and a financial specialist. We deal primarily with farmers, and we go to the farm on the farmer's schedule. There are no set office hours. We are open 24/7, and we meet their needs on their timeline. We look to build the relationship first. As has been mentioned earlier, rural people are very independent. They're very self-sufficient. And you have to gain their trust. So we strive to just listen first. Our process is what we term an formal process. There is no formal intake. We rely on the expertise and experience of our family consultants, who are all licensed social workers, and our financial consultants to assess and determine what are the best steps based on what that particular family's needs are. One of the strengths of our program is that our social workers enable us to understand, observe the environment, read the body language, and understand the dynamics within the family. And lastly, we believe that the best solutions for every farm family are solutions that come from the kitchen table. What may work for one family may not necessarily work for another. And we strive to help them identify what are their goals, what are their objectives, and how can we best assist them in attaining those goals and objectives. Next slide, please. I would like to give a little context to the early days of New York FarmNet. In 1986, when the farm financial crisis hit the farm community, FarmNet was initially created to assist New York farmers with trying to save their farms with legal and financial help. But in the debriefing with these consultants, who were all initially financial consultants, a common theme began to emerge. And that was financial stress exacerbates mental health issues. And a mental health issue or crisis can severely impact a family business. And after considerable conversation, it was decided we'll try adding a social worker or a trained counselor to the team. And immediately, the dynamic of the process completely changed. It was no longer just a purely financial conversation, but it also became a process of dealing with the problems and then healing and finding a solution. We strive to save every family farm, but we know we can't. But we are determined to save every family, regardless of the financial outcome. Next slide, please. As you can see, we have consultants who are scattered across the state, from the eastern end of Long Island to the northern Canadian border and out to the Great Lakes and everything in between. New York, for many people, is New York City, but New York City is a very small portion of New York State. It is a diverse region, both in terms of economic activity, culture, and we strive to meet people where they are. We even have a consultant down in Brooklyn to assist with urban farmers. So if you're a farmer farming in New York State, New York FarmNet wants to be there to help. Next slide, please. Why do farms call? Variety of reasons. Farm transfer, passing it to the next generation, estate planning, business and financial questions, stress, depression, anxiety, suicidal indications, drug and alcohol abuse, communications within the family, a sudden loss on the farm or a severe accident, divorce, the breaking up of a family. Next slide, please. The stressors New York FarmNet sees most often is who's going to take over the farm. Many of the farms we work with have a legacy of farming, 3 or 4 or more generations. And the responsibility of keeping it going can be overwhelming. And the question that many, many farmers carry every day is, will I be the generation that loses what my family has built? There are typical business challenges for farmers: commodity prices, cost of production, debt service, paying the bills. And for many, this is an underlying stressor that can build up over time. And in many cases, it's a conversation that comes too late. Farmers believe if I just work harder, if I put my head down, my shoulder to the task, these things will go away and I'll get past it. But we find that as time goes on, these stressors can add and exacerbate not just their own personal mental health, but the health of the family. Next slide, please. Many people believe that working with your family is the dream, but many can tell you it is a nightmare. Working with your family is extremely hard. It creates many problems and causes many great challenges. In some cases, there are three generations working together, but they're not always on the same page. You'll have conflict between adult siblings, conflict with older parents, conflicts among the extended family, and this will build over time. Next slide, please. And then the same challenges of everyone else. Farmers do not live in a fairyland. They deal with depression, anxiety, drug and alcohol use, divorce, illness, death. Everything that can happen to anyone and to all of us does happen to families in rural communities. Many times, people in an urban area will say to me, "You're so lucky to live in the country. It must be wonderful." And I say, it's no different than living anywhere else. We deal with the same problems, challenges, and disappointments as others. One thing that we have seen recently in the last few years is an increased concern about the elder care and the isolation of many elderly people in the community. Divorced or widowed individuals who are living alone, they are isolated, they are not comfortable with technology, perhaps they do not hear well, so the telephone is a challenge. We're seeing this as a rising concern, as well as what we call the sandwiching. I'm trying to raise my children and deal with my elderly parents at the same time. Again, issues that many, many people deal with, but the availability of services and support in a rural community is very, very difficult to find. And finally, the divide between rural and urban cultures. Many people say to me, "What are you talking about?" Rural communities have a very different culture. Not better, not worse, just different. And it is grounded in a sense of self-sufficiency, independence, and can-do attitude. And while that can be admirable at times, it can also be the detriment to me asking for help. Because I'm so used to doing everything on my own, why can't I fix this? When I talk to policymakers, and unfortunately too many of our policymakers are from an urban setting, they do not even acknowledge there is a difference between urban life and rural life. And many of you who work in rural communities will attest to this. And I try to explain to them, we are more than just a place you go for 2 weeks to get away from the stress of the city. Next slide, please. What can a farmer expect or a farm family expect when they contact New York FarmNet? We have a helpline, a 1-800 helpline that is staffed 24/7 by a real person. They will get a return call from a consultant within 24 hours, and an on-farm or Zoom visit will be scheduled as soon as possible. In the event it is determined that they need professional help, they will be referred to that professional help as appropriate. If that involves a medical emergency, we make sure they're put in touch with 911 or again, medical professionals. But sometimes it's a legal issue that we cannot help, so we'll make sure we get them in touch with a lawyer. Maybe they have tax issues. We'll get them in touch with a tax accountant. We work with the family as long as they desire. So some visits last 2 or 3 times. We have other cases that have gone on for a year or 2. As long as the family continues to need our assistance, we will work with that family on their time schedule. Also, the seasonality of farming gets in the way of things. We're now entering the planting season, the haying season, the cropping season. Many of our farmers will put off meeting with us for a couple of months as they turn their attention to the work that needs to be done. And then come fall, early winter, we pick back up and continue on with them. And lastly, and most importantly, it's the confidentiality that we are very, very focused on. Because we don't ask anyone to go anywhere and we come to the farmer, we're able to maintain confidentiality from the standpoint of It's just a car in somebody's parking lot or their driveway or their dooryard. And there have been farmers who have been asked by a friend or a neighbor, hey, I saw a stranger's car in your yard. Was someone visiting? And many a farmer said, oh, that was just a salesman, even though it was one of our consultants, enabling them to protect their own confidentiality. We take confidentiality so seriously that no one in the organization will know the specifics of a case other than the two individuals working that case. And only after a case is closed do I, as this executive director, even look at the case notes just to see how things have gone. So again, very, very important. And our clients are very, very appreciative of that. Next slide. In the past number of years, New York FarmNet has tried to take a more proactive approach towards mental health. And we have become a leading educator and advocate in New York about improving mental health education and awareness within farm communities. We have partnered with numerous organizations across the state, as well as agricultural service providers, the individuals who work directly with farmers day to day, to educate these individuals on how to work with farmers who are in crisis. Some of the partners that we have worked with, we've co-sponsored educational events, outreach events, and we continue to support each other to leverage each other's expertise and our resources to try and achieve a greater penetration within these communities. We work very, very hard at improving mental health literacy. And we strongly believe, and it's been told to me by many, many of the social workers who work with me, that the first step in addressing a mental health situation is a conversation. And whether that's me talking to my friend or someone else, but the conversation is always the first place it starts. But to be comfortable in having a conversation, I have to acknowledge that it's okay not to be okay. Next slide, please. Some of the presentations that we put on a regular basis: Talk Saves Lives, program about suicide awareness, mental health first aid, difficult conversations. How do you have a difficult conversation with your family or a coworker? Stress management on the farm, finding the balance between work and life. How do I get it all together? One of our popular programs is You Take Care of the Cows, but who takes care of you? We talk about mental wellness and resilience. And then, as I said, working with service providers, techniques when dealing with stressful situations. Many service providers who work with farmers are often put in a position of having to bring bad news to a farm. A good example is a milk inspector. Perhaps I have to turn off your milk. In other words, we are no longer going to pick up your milk because of a particular reason. I'm now telling an individual, I don't know where your next paycheck's coming, but we're not buying your milk. How do you have that conversation? Next slide, please. I wanted to share an example that sometimes the simplest things can have the greatest impact. And this year we tried a program which we called Farmer Friday Coffee. And it was a very simple concept. We took a local diner and we invited the farmers in the community to a free breakfast with the objective of bringing together people in the winter to just talk. Week 1, 12 people showed up. Week 2, 24 showed up, and many from the week before brought someone with them. Week 3, 40 people showed up, and we had to ask people to leave after the 5 hours. And in week 4, the last week we put this program on, the question was, will you be hosting this again soon? We were so pleased to hear how many had enjoyed this. Most of the farmers were older and retired. They talked about loss, pain, loneliness. They supported each other. Connections were made. And as one person told us, these past few weeks, they had stopped feeling alone and felt they could begin to reach out to others. And again, it goes back to what I said a little bit earlier. The healing process sometimes starts with a conversation. We had such success with this program, we're going to expand it into other communities around the state, and we're very, very excited. But creating that sense of community, that you're not alone, encouraging others to talk about what they're dealing with, and helping through lived experience to share those experiences helps others realize they are not alone. It's important to understand that FarmNet did not come up with this formula the first day we started. We figured it out as we went along, but it has proven to be a model that we are happy to share with others. Again, thank you so much for this opportunity, and I look forward to any questions you may all have. Thank you. Next slide. You can contact us through our website, or if you know a farmer in need, have them call our 1-800 number. Again, thank you.
Thank you so much, Greg. And thank you to all of our panelists. I am now going to stop sharing screen. This is Monica, by the way, and I'm going to invite all of our panelists to rejoin us for some question and answer. Thanks to folks who have already been sharing great questions in Q&A and the chat. I would like to, let's see, open it up with a question for the audience for you all to think about as we start to address the questions that have already been asked. Is there anyone who's joining us today who is looking to bring more community-based mental health services to your communities? And if so, are there any barriers that you find that you're facing? Or is there anything that you want to talk through with any of our panelists in terms of any challenges you're facing to get these programs up and running? So I'll let everyone percolate on that. Please let us know in chat or in Q&A. Turning now to the questions that have already been posed. I see there is one on how are you differentiating between rural and frontier communities? I can get us started. I know that our friends in Alaska also touched on this a bit. I don't know that there's particularly one definition. I know that the United States Census seems to differentiate between the two based on population density. And so we talk about urban, suburban, rural, and frontier communities, with frontier communities tending to have less population density than rural. But certainly population density is not the only way to describe these wonderfully diverse communities. So I'd love to open it up to our friends in Alaska and then our friends in New York, if you have anything you'd like to add on this question.
This is Zio. Just to tag on to what Monica had mentioned, a lot of it does have to do with population density, but also we are very geographically spread out, and to be able to access our communities, the fact that we have to use ATVs and boats and airplanes, that to me is really speaking to the frontier nature of Alaska. And those are always things that come into play when we talk about getting healthcare to people, is how do you navigate the geography? How do you get from one community to another? And will the weather allow you to do that? And if not, what do you do in the meantime? Because the need is still there.
It's hard to describe New York as frontier, so we tend to think rural. But similar to what they have challenges with in Alaska, it's accessibility. When the nearest facility, be it healthcare or mental health care, is 50 miles by the map, but it's the middle of winter, you live on the backside of a mountain, your vehicle is undependable, and maybe you only have a quarter tank of gas, really not going to jump in the car and rush down the road. Um, I think all of us who work out in rural and frontier areas will say, ultimately, from my perspective and my experience, the ability to get to them sometimes is the difference between them getting any help. If they can't get to me, they are not going to come. But if they call and they know I can get to them, more likely, at least we can quote unquote stop the bleeding.
Thank you both. We had another question, and this one I think is for Greg, in terms of how do you protect the digital footprint of confidential data that often sits outside person to person fidelity to confidentiality?
Good question. Our consultants will submit case notes to what we call our database, which is our process in which they track the progress of the client's case. That information is stored on a server at Cornell University. And in every conversation I have had with Cornell University about the integrity and security of that server, they have assured me that they have as strong a firewall as anyone can expect short of the US government. We can only do what we can do. Having said that, every consultant will tell you they are careful as what they will put in the actual written record. So they are not disclosing, because we don't have a formal intake form that they need to complete with a lot of quote details. They will oftentimes put only enough information in that file so that we have an awareness of what's going on, what some of the key issues are. But you will often find that names are deleted. They will use the first initial. When we communicate organizationally about a case, we use case numbers, not names. And I have gotten into many discussions with some of our stakeholders about the desire to access these records. And my response has been, serve me a subpoena, clear it through Cornell Counsel. But until then, no, this is confidential and we will not disclose this information. Having said that, it is important to say this. Our social workers do understand and are very clear, however, their code of ethics and their licensing requirements may require, in a situation, that they do have to report a case to the state. So again, if they see something that they are legally required to report on, we tell them, follow the law, do what you have to do. So again, and it goes to what I said, we trust the judgment of these individuals. They're licensed social workers, many of them 20, 30 years in the field. They know what they're doing. I'm going to trust their judgment to do the right thing.
This is Monica. Thank you, Greg. I'll open it up if any of our other panelists would like to touch on the confidentiality or privacy question. No problem if not. We've got plenty of additional questions. The next one is for our friends in Alaska. Do you have any training manuals or materials that you can share? Anything that's non-proprietary, like manuals, so that folks can learn more about your program?
Well, I will start. This is Zio with ANTHC. I will start by saying we actually have a lot of information about our program online. You can just Google Behavioral Health Aid Alaska, and we've got a lot of information up there. So far as a manual or non-proprietary materials, we actually do have a behavioral health aid manual. It is electronic, which just really, so it's online. People are required to have their own login and profile to access that. And right now it is limited to individuals who are employed as a behavioral health aide or their BHA supervisor. We do use the manual as a complement to their training experience. And the EBAM, it provides a lot of information. Some of it is foundational information related to how do you provide quality behavioral health care to individuals or in your community. But there's also a really large section that is referred to as the client. They have client care topics. So very specific topics like whether it's depression or anxiety or domestic violence that really walks the BHA through how do you prepare for meeting with a client with this situation or condition? What kinds of questions do you ask? What kinds of things do you look for? What are the things that need to be documented? What are some the most effective interventions for such a condition or circumstance? And then what do you do for reporting? So it really walks them through what do you do for these different appointments, or at least gives them a foundation for that. It is not something that is publicly available at this point in time, but as I had mentioned with the nationalization effort, folks who do decide to develop and implement a behavioral health aid program, they will have access to that manual as well.
Thank you very much. This is Monica again. We've got some questions in the chat about services specific to children and youth. Josie, you mentioned a bit about increases in, unfortunately, youth suicide. Would love to hear your thoughts and experience in bringing services specific to children and youth in your community.
Well, we partner with our school district, and so behavioral health aides are encouraged to go into our schools to do outreach and just to do activities and provide safe spaces. And if you look behind me, you'll see I have Legos and I have totes full of toys in there. So we also work with parents and like teaching parents child-directed play, and having them practice that here in the office. Because if parents can just spend 10 to 15 minutes or just be mindful of the activities that they're doing with their own children, that can have more of an impact than their child coming into counseling. Doing just 10 to 15 minutes, a day or even a few times a week with their young people in their lives can help out a lot. We support youth activities that are healthy, and even present at them, like maybe culture camps, or we do subsistence activities with youth. Doing Inupiaq days or UPIC days in the schools, like week-long cultural events, taking youth out berry picking, teaching them about the plants that are medicinal or really healthy, because like the harsher the environment that like plants grow in, the more nutrition they have. And so we do a lot of subsistence picking. We have a real short growing season, but we do like some gardening because we have so much sunlight here in the summer months. But we do a lot of fishing and picking and just teaching youth and getting them involved in those activities, and just a way to connect with them and helping parents connect with their kids too.
Please.
So this is Rebecca again, Becky Boss. And I think what Josie mentioned was what I referenced earlier, which was thinking outside the box and finding the partners that are not usual, and thinking about schools as a resource for students beyond education, but also to address mental health. And many states are engaging their Medicaid to support mental health treatment and supportive mental health in school settings and systems. And, many schools are engaging with bringing services into the school setting, either before, during, or after school, to support students who are struggling. And a lot of teacher education and activities that are going on through various systems in states and communities are very important to address the needs of the youth. And in rural communities, it's the partners that you look to that you're not going to have the specialty child psychiatry necessarily available in your town. But also, again, the importance of telehealth and the ability to bring things on board like communities of care and the ability to connect with the resource that you need perhaps in a pediatrician's office, speaking with a psychiatrist that's miles away, but still the ability to connect and to provide that resource through various systems.
This is Monica. Thank you both. We have gotten some questions about the use of telehealth. Would love to open it up for anyone who can share. What does access to telehealth look like for your community, and how do you incorporate that into your service model? Maybe we'll start with Greg and then go to CO.
Thank you, Monica. Prior to COVID, we didn't use any sort of technology other than the phone call after we had met with clients. COVID taught us the value of Zoom. So we will utilize Zoom if the client is comfortable with Zoom. Now, again, I will say every consultant will tell you we would love to get to the farm first. The social workers will tell you I can learn more sitting in a kitchen in 2 hours than I can in 20 hours of Zoom. And the social workers here can share why that is. But once they've reached a level of comfort with the client and understanding, we'll often use Zoom for check-ins, see how things are going. At the same time, however, many of our older clients don't even use email. So to try and get them to use Zoom is not fair. Again, we also have a large community of plain folk, the Amish and Mennonite, who have no access to technology. So we are always aware of what is the most comfortable means of communication that you as the individual would like with us. You find a farmer 35 years or under, 21, they'll Zoom you all the time. So again, whatever works, and it goes back to what I said, what are the specific needs of this family and what is the most effective way to work with that family? That's how we operate, and that's how we will continue to operate.
This is Zio. I have a little bit to say, and then I'll actually kick it over to Josie, so we can again hear about what that's like in the communities. But I will say that in Alaska, as you saw on that map, we are all really spread out throughout the state. And so telehealth is actually a really important tool for us to be able to connect across our system. And what that means is that in most clinics and of course our hospitals, they have video technology where people can go into the room and connect across there. Internet connectivity continues to be an issue for some of our most rural communities. However, what I have found is that in villages, probably the most reliable internet connection you'll get is either going to be at the school or it's going to be at the clinic when it works. And so this is definitely a tool that is used pretty regularly in our healthcare system. But what that actually looks like, boots on the ground, I will turn that over to Josie.
Yeah, I'm here at the clinic using Zoom here in my office. And so we have all iPads in all of the behavioral health aid offices in our region, and they're able to use the iPad to connect clients with their providers. We try to set it up in a room that's private. We have like these sound machines that we put up outside the door so they can have more privacy. And some of our clinicians also do telephone and video appointments in between with people in their homes in between their visits here. They try to come at least once a month, so they're here face to face in person. Sometimes the first contact with people is usually over the phone because they call the urgent care or on-call services by telephone. And then when the clinicians travel here to the village, they meet in person with the clients. Schools and clinics do have the best internet, but even then it's not always working very well. Like I think one of our villages right now, or two of our villages, they're having trouble with power until all the ice goes out and they can get a barge in to bring fuel. They're out of gasoline for the entire community. And so they're running on backup generators right now, which affects the internet. So we do have to rely on telephone still. I think for us during COVID, it was a little easier because we were already used to doing everything through distance. And so it wasn't a real big change for us. It was something that we were already familiar with.
This is Monica. Thank you all. I saw we got a question about whether access to devices was a barrier to accessing care. I saw some ideas start to pop up in chat. Remember, healthcare clinics can always purchase hotspots for clients who want telehealth. Are there any other lessons learned or tips for folks for whom having actual access to a laptop or a tablet or a phone that connects to internet and ways to connect folks with those devices? I think I heard some ideas about schools and libraries as sources.
This,
Becky, I'll just add during, COVID changed a lot of that for a lot of communities, and there was funding to be had through ARPA, which helped provide a lot of people who weren't able to purchase their own devices access to things like iPads and phones that would connect them. And so minus the ARPA dollars, I'm not sure that there's a lot of resource still remaining out there to help people access. And so if individuals don't have access, again, probably the best solution is to engage with a resource that does. And the other thing that I thought about in terms of thinking outside the box and using telehealth with individuals like Greg mentioned that aren't comfortable with email is looking at addressing confidentiality and bringing in partners to support individuals in accessing the care that they need. And it might mean a family member is going to check the emails, and then you have to have a resource or a release of information allowing that to happen. But really looking for those critical partners within the person's community and infrastructure that can bring them, the ability to use the telehealth or some kind of technology to support their ongoing care, and it sometimes needs to be thinking outside the box.
Thank you, Becky. Theo, was there anything you wanted to add on that?
The only thing I was going to say is that I have found a lot of people in our rural communities and our villages have been getting access to Starlink. And sometimes Starlink they have had funding that has come through either their village tribe or tribal council that is really, they recognize that connectedness is important. And so there's been some funding that has helped to bring Starlink to communities, and that has increased access to care as well.
This is Monica. Thank you all so much. And thanks again to everybody for joining us today. As we look at our last few moments together, I'm going to open it up for a round robin around the room with any closing thoughts or tips or resources or takeaways you want to encourage folks to take home with them. Let's go in the opposite order that we presented. So we'll go Greg, then Josie, then Theo, then Becky, and then I'll close this out.
Thank you, Monica. I would like to just address one question that was raised in the chat. Given the inequities Black farmers experience that may impact their mental health, how does FarmNet approach the work from a culturally responsive perspective? And I just want to touch on that, and also want to touch about Latino or Spanish-speaking farmers as well. We recognize that as a primarily white organization, we have to be very sensitive. So the approach we have taken is worked with organizations who support BIPOC farmers and offer our services to them and their staff, and let them introduce our services to their community. If they would like us to participate, we're available, but if they ask us to step back, we respect that. And so that's how we've chosen to do it. With regards to the Spanish workforce, which is a large amount of the farm workers in New York State, after January, there was a considerable amount of stress from that community. We are very cognizant to remind them we are not agents of the state. We also have bilingual consultants who are available. And I'm happy to say that this week, actually literally this week, we're rolling out a 1-800 helpline Spanish only to provide access. And so that's really it. But the big takeaway, and I think it was very evident, Becca talked about it, Rebecca talked about it, Alaska's talked about it. Everything comes down to what works best in your community, in your region. I've had a number of people say, you should take FarmNet National. And I say, no, I don't want to take it national. What works best in your community is what will work best. And for someone 1,000 miles away to start dictating how you're going to do things, it will not work the way it should. The best help comes from your own community. Thank you.
Thank you, Greg. Josie?
Thank you. I like that. One takeaway for me is just to be really creative and to make as many partnerships as you can with all the resources that are out there. Because we can, like on the medical side, they often have more money than we have on the behavioral health side. And so I partner with the medical providers, and I can borrow their equipment when ours isn't working. Just as many partnerships as we can, and also focus on strengths, because we talk about how we have so many of our numbers. We have like the highest number in everything bad and the lowest numbers and everything good. So I try to find the things that we are really good at and things that are good. Like, for example, Alaska Native and Native American elders, we have like one of the lowest suicide rates ever because we value our elders, and like just trying to build on find what those little strengths are and build on those, on the good things.
Thank you, Josie. Theo?
Yeah, hard to follow on those comments, but I agree. I know in the chat someone had mentioned that culture is prevention. I firmly believe that. I also believe that culture is healing. And so as we look at how to meet people where they're at and identifying the most effective interventions, I agree with what Greg is saying as well. You know, a lot of the answers will come from the community. And so for those of us who are in a place where we can really uplift our community members, I strongly encourage you to do that, because oftentimes the solutions are found right there in the heart of the community. And they just need someone to help uplift them.
And this is Becky, and it's really hard to follow those three. I'm just so grateful and impressed by my co-presenters who are boots on the ground, meeting the needs of individuals in their communities. And just thank you for the work that you do. Josie really stole one of mine that I would say, which would be create partnerships and find those resources within the community that you can use. But as a former policymaker, I will focus on the framework of policy. You know, for anybody that is a policymaker in their state, in their community, in their county, I would say examine what policies you have, regulations, processes, funding that get in the way and present barriers to those community solutions, and do what you can to rectify that.
Thank you all so much. I have the unenviable job of closing us out. My big takeaway from this is that we can provide community-based mental health services in every community. Thank you to all of our presenters for sharing your expertise, and thank you to everyone who took time from your busy day to join us today. We look forward to being back in touch with the recording and the slides and all of the resources that we covered. Take care. Thanks for joining us.